And thanks for having me here, guys. Like it's really a privilege to be here with a lot of my colleagues who I've worked with over the years, and a lot of you guys are very experienced with this kind of stuff. So please feel free to chime in or ask questions hereafter. Yeah, it's a collaborative discussion, so it'd be great for you guys to pitch in. So yeah, these are my disclosures. Nothing major here. And then yeah, I just want to acknowledge that we're on Treaty 678 territory for our province. And I mean, I'm not going to go into COVID-19. You guys know enough about it already. It's encompassed our daily lives. But what I will discuss is how it's sort of impacted substance use disorder during our times. And so I attended a recent discussion forum internationally with people from China, Iran, Europe, all over Europe, South America, North America, to discuss how people across the world have sort of been dealing with the challenges of COVID-19 and substance use. It was mostly a clinician forum, but there's some people who lived experience on there as well. And there was two predominant themes. One was that there was an increase in substance use, mainly because of negative emotions in the general population, and also because of mental health burdens from isolation. And while this seemed to be the most predominant theme, there was also another theme that came up, that a lot of people were ingrained in their recovery. And talking to some of my clients, I've seen a mixed bag as well. Some of them are saying that because they're at home, they're no longer triggered to use, they're no longer driving by the liquor store, they're no longer hanging out with the usual friends that they used to hang out with and use substances. So I've heard both sides of this spectrum. So very interesting. The other thing that we hear a lot of right now is that, and I hear this directly from my clients, is that there's been a huge change in the supply of substances across the border. So within both across the BC and Washington State, as well as Alberta, Montana, because not that many people are coming across, the drug supply is different. The price of fentanyl, methamphetamines has increased drastically. So before, methamphetamines was about maybe $10 to $20 a hit, more like in the $10 range, but now it's like 20 to 30 to 40. And then I've been hearing the same thing with fentanyl as well. Fentanyl was usually $20 a hit, and now it's about 30 to 40 a hit. So quite a bit more expensive, and fentanyl is always more expensive than methamphetamines, and so it's quite astounding to see that they're at times equivalent at this moment. What this has done, and there's a lot of experts on this phone call today, so I'd love to hear your opinions on this. What I've seen happen within my own community with my own clients is that some of them are using more than they used to. So they know that the substance that they're getting is diluted, and so they're injecting more of it. And of course, as we know with fentanyl, there's a cookie dough effect in which you don't know how much you're getting. And there has been a string of overdoses, especially with the drop-in center in Calgary that we've noticed. Okay, so opioid use disorder, I'm just gonna, sorry, I can't see some of my screen here. Opioid use disorder as a potential risk factor for COVID-19 mortality. So just in general, and this is mostly based off of animal studies, there has been a correlation between immunosuppression and opioid therapy. We see this with other substances as well. So with alcohol use disorder, we see mild suppression to a certain extent, especially with heavy alcohol use, which could cause immunosuppression. With methamphetamines, alcohol as well, and to a certain extent with opioids too, we see a lot of malnourishment and malnutrition. And for this reason, people's immune response is somewhat decreased, and they could potentially be at higher risk for mortality because of COVID-19. So clinically, what we should do, most of you guys are doing this already. A lot of you guys are doing virtual care, which we should be encouraging and we should be doing for most of our clients. It's been an ongoing thing actually in Alberta for many years now. So Nathaniel Day's virtual ODP program has been operating province-wide, especially in rural communities for the last while. It's been working well for him. He does it both via telephone as well as via teleconference and telehealth. So it's worked reasonably well for him. He says he's had no major issues. And I've been doing it as well with the Grand Prairie region for the last 3 years too. And it's a fantastic way to do care. It's not very difficult to do, especially with substance use disorder. And in times, it's actually, some people feel it's less stigmatizing. So we have data from Northern Ontario that was done by David Marsh, who sort of demonstrated that telehealth actually reduces stigma to a certain extent. More people attend their sessions. They're afraid of meeting their local physician because of their small communities and the stigma that's associated with that. So telehealth is a viable option for them in many respects. It allows them to keep a little bit of an anonymity, which has been hugely helpful for them. So a couple other things, don't let your patients run other medications. Talk about being careful with their dose. Talk about the delivery of the dose and working out the logistics as to how they get their medications. And then don't have them come to your clinic unless absolutely necessary. For internal medicine, which is what I also do, I sometimes do have to do physical exams, but for the most part, I can get most of the history and the story from the clients directly via telecommunications. And with substance use disorder, this is actually particularly easy. So yeah, just to be aware of that. Some other key pieces here is suspend all urine drug screens. For buprenorphine and naloxone, I try to avoid this anyway. I find that there's no utility behind it. But what I try to do instead is I try to establish a working relationship, a relationship of trust with the clients. And it works for the most part. Right off the bat, I ask them what their goals are. They tell me what their goals are. I tell them to be very truthful with me with what they're using, and we work on whatever substance they're using together, and we do not do negative reinforcement. Urine drug screens does come from a place of negative reinforcement in which we penalize our clients if they're no longer being adherent to their medication or they're having other impurities in their urine screens. We do not work with that atmosphere and that mindset. We try to provide positive reinforcement, encourage them if they're doing well. If they're not doing well, we work with them to figure what needs to be done. Where we can, deliver the medication as much as possible. No daily witness dosing, especially for buprenorphine and naloxone. No in-office invitation for home induction, which I'll go over in just a bit. And then give upwards of 60 days of dispensing. I actually give 90 days worth of dispensing with buprenorphine. In Boston, where I did some work as well, we would give 4 months worth to people who are homeless. And that's a big question mark, right? Because here we do not give it to individuals who are experiencing homelessness because they have no place to store their medications. But over there they were. So it quite surprised me. And so it really sort of steered my prescribing practices to a certain extent. It made me realize that we can get away with a lot more than what we're doing. With methadone and SROM, of course, it's a bit different. So you have to be very careful with that. There's a risk of diversion. There's a risk of overdose with this. So I'm a bit more careful with that. I do use urine drug screens for that population group, but during the time of COVID, of course, I've suspended that as well. And have been providing carries to my stable patients, upwards of 14 days for methadone as well as for SROM. But again, it's kind of a case-by-case basis to who I give that to. And the other piece that we try to do is we consider discussing rotating to buprenorphine naloxone from methadone because of that added safety benefit. So Health Canada has provided a class exemption for patients, practitioners, and pharmacists. This has been great for our patients and now allows pharmacists to extend prescriptions. It permits the transfer of prescriptions to other pharmacists. They can take verbal orders and extend a prescription that's already stable. And they can also deliver prescriptions of controlled substances, which is huge for our clientele. This has been going on to a certain extent for a while now in Alberta anyway. The ACE team in Edmonton has been fantastic at delivering opioids, methadone, Suboxone to their clientele on a regular basis to ensure that they receive it, especially in places like the River Valley, so with encampments. So it's really great to see Health Canada pushing for this as well. I was asked to discuss briefly about rotating from methadone to buprenorphine, Suboxone, sublingual. So our traditional method of doing this is with a slow wean off of the methadone. This takes months to do. We slowly decrease them down to about 30 milligrams per day from whatever dose they were on. Then we get them to stop for upwards of 72 hours, sometimes even more. And then we wait till their CAL score, of course, reaches above 12, and we start them on buprenorphine. This has a lot of concerns, of course, as well, because a lot of people cannot get down to 30 milligrams to start using again. It's hard for them to deal with the cravings. They experience prolonged withdrawal during this time period as well. Maybe not as high as a CAL score of 12, but still it's irritating nonetheless. So what we've been doing quite a bit of is bridging. And so the way that bridging works is that we slowly decrease the full agonist opioid, whether that's methadone, whether that's illicit substances like fentanyl, or whether that's prescription opioids like Percocets, and we slowly up titrate the level of buprenorphine, which is a partial agonist at the same time. I know some of you guys on this call have already seen these slides before. The big thing that we worry about but by starting with buprenorphine really early, as most of you know, is precipitated withdrawal. And that's just because of the high affinity and long half-life of buprenorphine for mu receptors. It doesn't exactly displace the full agonist opioid, but it's easiest to picture it that way. And the way that I look at precipitated withdrawal is it's like slamming on the brakes of a car. If you slam on the brakes of your car, you rapidly deaccelerate. And that withdrawal experience that you have can be traumatic and can be very difficult to deal with. The way that we work with bridging is that we slowly provide a small amount of buprenorphine so that you're not rapidly slamming on the brakes, but rather you slowly go towards a net effect of a partial agonist, where you're sort of in a partial, where you're just kind of partial withdrawal, although you're not in withdrawal. Again, a very slow process, so you don't experience that sudden halt. The Bernese method is the classic method. This was done from a paper back in Switzerland. So basically what they've done is they do 0.5 milligrams. The Bernese method was actually using smaller doses than that. It was like 0.2 milligrams. But what we do in our sort of modified method is we use 0.5 milligrams BID, which is about a quarter of a 2 milligram tablet. And we slowly increase it. So after a couple of days, I bump it up to 1 milligram. A couple of days after that, I go 3/4 of a tablet, which is hard to do. So you just give them three pieces of the quarter tablet. And then at around day 7, we go up to 2 milligrams. You can do a 3-day protocol versus a 7-day protocol. The way that I do this is I usually give it more time for a lot of my clients. I usually like to go 7 days because it's easier to do. And I find that clients feel and express less withdrawal with that protocol. If they really want to go quick, we have done 3 days quite successfully as well. We do have a Butrins patch protocol that we work with. Butrins patches is a more standardized way of giving buprenorphine. So the thing with the tablets is that when you quarter them off, for example, you don't know how much buprenorphine is going where in which quarter of the tablet. It's an uneven distribution of the drug within the tablets. What the Butrins patch does is it allows you to give a more consistent amount of drug. So the 20 microgram buprenorphine patch is the equivalent of 0.48 milligrams of buprenorphine Suboxone. So that's about a quarter tablet again. So what we do is on day 1, we put 1 patch on this person. On day 2, day 3, we lower their dose by 1/3, give them a 2nd patch. Do not take off the 1st patch. And then day 5, we add on a 3rd patch and we dose reduce again by another 1/3. And then by day 7, we do not give them any more full opioid agonists, and we remove all 3 of our patches. And then we start them on the induction process. And there's no cow score required for here. They won't be feeling withdrawal. So you then give them the buprenorphine and then you up titrate them as fast as possible. There's a fentanyl bridge method as well. It's somewhat similar, but you should be doing this of course, an acute care setting as opposed to a home-based setting, just because it is using a fentanyl patch and there's a risk of respiratory depression. Essentially what it is that you stop your methadone for preferably a couple days, if not more. Here they've only kept it for only 1 day. And then you put a fentanyl patch on them and you keep it on for several days. And then you stop the fentanyl patch, you remove it. And then within 3 hours of taking off the fentanyl patch, you do your induction of buprenorphine that you normally would do. Again, the client should not be feeling any withdrawal symptoms at all, so you don't need to take a cow score. And you up titrate as fast as possible. Puya Azar kind of developed this method in BC from the BCCSU, and talking to him, he's had no complications. I've done this with, I would say, maybe 20 of my patients over the last year, I would say, in the acute care setting, and it's worked reasonably well too with no precipitated withdrawal. We also have an SROM strategy as well, and this is a bit of a different strategy. So what we do is we try to convert methadone to buprenorphine using an intermediate, which is SROM. So we dose convert the methadone to SROM in a 1:4 ratio, sometimes a 1:5 ratio, even sometimes a 1:6 ratio, depending how we feel about the clients. And then we increase the ratio as needed to help with cravings for days 2 to 5. Day 6, we do the last single dose of SROM in the morning and then wait 24 hours. And then we do a regular induction of buprenorphine after waiting for a cow score of 12. or alternatively, you can just kind of overlap the micro-induction with it, which is what we've also been doing. So around day 3 to 4, we start doing the micro-induction that overlaps in the SROM. That works reasonably well. Here's sort of a table of the different methods. We do have an article that was published that we did with the BCCSU, looking at multiple different methods. So there's more methods listed in that article. I think we've listed about 10 to 11 altogether. So please have a look if you want to know more. And there's again more detail on how these protocols work there. So for opioid agonist treatment, what we have been doing with our ODPs for the most part, both in Calgary, as well as the virtual ODP and the GP ODP, is home induction. Home induction is where we actually don't witness the client starting their buprenorphine, but rather we give them the medication and we get them to take it at home. And so there is some evidence for this. There was a case series of home induction, 103 patients, mixed batch of illicit substance use, prescribed pills, and methadone. And what they did was they followed the protocol that we normally do to the T. So they gave 4 milligrams of sorry, I should say the clients took 4 milligrams of the buprenorphine after they reached a COW score of 12 or more. Then after that, they added 4 more milligrams as needed every 1 to 4 hours for a maximum of 12 milligrams. And then what they found was that the 1-week retention was quite good, was 73%, and was comparable to in-office induction. As you already know, the thing that we fear the most is severe precipitated withdrawal, and that was not the case in this particular population. No severe precipitated withdrawal at all. And then 5 patients had mild to moderate buprenorphine-prompted withdrawal symptoms, which we see often as well: anxiety, nausea without vomiting, sweating. And sweating is a natural side effect of buprenorphine anyway, as it is with methadone. So if they're on a stable dose, regardless, they sometimes may sweat. And then, of course, sleeplessness and sedation, musculoskeletal aches. So that was the protocol that they used. There was another study that was done that was a choose-your-own-strategy approach. Out of 79 patients, 66 had received home induction kits. And these kits were prepackaged kits. There was an instruction sheet in them, 10 2-milligram tablets, 4 8-milligram tablets, and 6 pills of ibuprofen, clonidine, and loperamide. With clonidine, you have to be especially careful on, just because it can lower your blood pressure. So your mouth is a bit dry right now. So definitely be careful when you do prescribe clonidine. Make sure you take a blood pressure of the client beforehand and sort of evaluate them, especially if they have blood pressure medications on board already. This is kind of what the instruction sheet looks like. This is what, it talks about what's in the kit, when to start the box and things not to do, how to take it, and then gives you the breakdown of the pills. And what they found with their choose your method study was basically that it was equivalent to in-office inductions. And then when they adjusted for baseline opioid use, age, gender, ethnicity, they found more or less the same thing, that it was quite equivalent, and there's no major concerns between the two. There's only one randomized controls trial that was done, 20 randomized randomly assigned clients to observe versus office-induced inductions. And then basically what they found was 60% successfully inducted were within each group, and 30% experienced prolonged withdrawal, and 40% stabilized by a week. It's quite a small trial. The protocol is a bit different. What they did do was they did 1 to 2 tablets after abstaining 16 hours or more from opioids, and when their subjective opioid withdrawal score reached greater than 17, this is like a self-administered score that they can do. And then both groups were instructed to take no more than 16 milligrams on day 1. I would actually wait more than 16 hours, and I think that's where they kind of ran into some issues. But overall, in the literature review, thus far, technical trials have been done that demonstrated unobserved induction were reasonable. The evidence was weak to moderate in terms of, and there was no differences in adverse event rates between the observed and unobserved inductions. And also there was insufficient or weak evidence in terms of any or no differences in overall effectiveness. So here's what we do in Calgary. What we do here is that we get people to stop all their opioids, and we provide them immediately with withdrawal medication. So we provide them with clonidine, again, monitoring for their BP, gabapentin, and also, if necessary, clonazepam. I don't do the clonazepam, but a lot of my colleagues do. On day 1, once appropriate withdrawal is reached, and again, many clients do not experience this withdrawal because of the medications that we provide, we initiate a 2 milligrams sublingual dose of Suboxone, and we ask them to take it repeatedly every hour up until 16 milligrams. So 8 more times, and then hold if they're feeling sedated or if they're feeling worse. If they're feeling worse, we tell them to take a pause and take a break and try to reinduce themselves after a few hours, and then call us if they need to. Then day 2, we start off at 16 milligrams the previous days, or whatever the previous day's maximum that was reached, and then give 2 more milligrams until they again decrease their withdrawal symptoms and they feel better. And we do it for upwards of 32 milligrams in total. We are finding that with our clients who are using fentanyl, especially, we have to go at higher doses. And so we tell them to rev up if they can to 32, and then we dose decrease right after that back to maybe 16 or 24. And we usually call our patients on a daily basis while we're doing this induction process, unless it's over the weekend. We give them a phone call, we make sure they're doing well, we repeat the instructions because the instructions can be confusing, and then we provide them with 28-day prescriptions as appropriate. So harm reduction advice, and we've got some experts on the line already for this, and so please feel free to jump in at the end of this. A lot of stuff is coming from the BCCSU, but a lot of it is also consensus-based as we're waiting for some more guidance. So do your usual education for clients who are experiencing COVID and self-isolation, require harm reduction. Of course, they're at increased risk of overdose because they're using alone. Buddy up, ask them to buddy up if they can, use FaceTime or use it in the same space as their friend, but stay 2 meters away. And then if they can, continue to use supervised consumption services or OPSs, because those are effective in reducing mortality rates. I know the sites are practicing social distancing as well within the facility, so definitely utilize them and encourage your clients to utilize them. So a couple more things. Most of our clients who use substances smoke anyway. They smoke tobacco, but they also sometimes smoke their substances. I do try to warn them that there's an increased risk of COVID-19 mortality because of smoking, as far as we know so far, and tell them that smoking their substance can increase their risk factor as well, so they take extra precautions. We try to educate them on handling parcels, and I tell them to sort of deal with parcels the same way they would deal with their produce. You know, clean it when it gets home, like Lysol it up with a wipe. Ensure they have a stock up of needles, syringes, and other injecting materials. And I encourage them to co-plan with the local harm reduction service. So whether that's SafeWorks in Calgary or HIV Community Link in Calgary, whether it's HIV North in Grand Prairie, they just changed their name. We try to encourage them to sort of co-plan with that agency to ensure that they have the right supplies. Also, I encourage them not to share supplies. This is especially important in my supportive housing facilities that I work with. They often do share cigarettes, joints, pipes, injecting equipment. Again, tell them not to do that. They shouldn't be doing that anyway. Reduce close contact, wash their hands, and also wash down the surfaces that they're going to be using on as well. And be very careful when they're preparing and handling their substances. And also when they do start to use, go slow and use a low amount as well, because again, we don't want them to use too much and overdose. And then some more basic stuff, like basic hygiene stuff that we usually do discuss and talk about. I also encourage them again to carry an naloxone kit and have an overdose plan. And then reuse breathing masks as available in the kits, if there is one available in the kits. So overdose management, this is a bit of an area of contention right now. I had numerous discussions with a lot of colleagues about this, and I'm interested in hearing your opinions as well. So what I've suggested, and what some of us as a consensus group, especially the drop-in center, suggested, is using naloxone 2-3 injections right away. If CPR is needed, ideally you would have a full set of PPE on board. And then if you are to do CPR again, you can do chest compressions, but try to place a mask over the client's mouth. And then don't do any airway interventions like bag mask valve unless you have full PPE and an N95 mask. If you don't have that, we're suggesting not to use it. AHS has come up with their own management guidelines. So they recommend calling 911 right off the bat, don PPE if available, and then administer naloxone. And then if you choose to provide rescue breaths, use a one-way rescue breathing mask, including included in the naloxone kit, and with a one-way valve. What they don't talk about, however, is whether or not to use an N95 or not. And so that's kind of the area that we're sort of questioning at this time. Continue to monitor the individual, assess response after 2 minutes. If no response, administer more naloxone and provide risky breaths as available. And then if the individual is breathing, place them in the recovery position, again, which is very important to do in case they say they vomit, they cough up. And then once the scene has been cleared once the scene has been cleared, clearly clean the area. And then, yeah, that's sort of the gist of it in a nutshell. So for our clients who are using alone, we have a program that we're sort of piloting in Calgary. It was supposed to be a clinical trial at first, and we're supposed to use just 15 people, but now we're in talks of scaling it province-wide. And I don't know if Kay is on the line. Kay, are you on the line? Nope, I don't think she is. So this is a program that we sort of developed, and sort of the basis of the program is that, and this is what the initial basis was that a lot of the overdoses that are occurring in suburban communities, with people who are appropriately housed, who are not utilizing supervised consumption sites because of stigma concerns. And we know that supervised consumption sites, based on the literature from Vancouver, shows that they're mostly effective for reducing mortality rates within the 500-meter radius around them, which is why it's so important to place these sites strategically, and to have multiple sites if possible. But again, the majority of the overdoses are occurring beyond this area. Good news is that opioid overdoses can be reversed, and supervised consumption services reduce mortality. But what we've done is we proposed intervention using your phone to engage in supervised consumption. So what it basically is you call in a 1-800 number, and you go through a process where someone supervises you for 15 to 30 minutes. I'm gonna take a pause right here and bring up a video that we've developed. Give me a quick sec. You guys, oh, can you guys see my screen?
Yeah, we got it.
Okay, awesome.
Welcome to the Alberta telephone-based supervised consumption service. What name may I call you?
Nebraska.
Hi, Nebraska. Where are you located right now?
Suite 515, 865.
And is your front door unlocked, Nebraska?
Yes, it is.
Excellent. And do you have an overdose prevention kit visible nearby?
I do, yes.
Excellent. What are you planning on using, Nebraska?
Heroin, and I plan on injecting.
And are you using clean supplies?
Yes, I am.
Excellent. And final question. Will you share your phone number in case the line gets disconnected? If I can't call you back, I'll have to call EMS. We will not keep your phone number after this call is complete.
Sure. 403 613.
Can you please leave your phone on speaker? I will check in with you every 5 to 10 minutes, depending on your preference.
Okay. Every 5 minutes.
Excellent. Talk to you in 5 minutes, Nebraska. Hi, Nebraska. We're at the 30-minute mark. I'm going to let you go now, but before I do you have any concerns or anything else that I can help you with, including other health services?
Yes. Maybe you can tell me where to get clean supplies?
Absolutely. You can go to...
Okay, just bring up my other screen. So yeah, our hope is that this service can actually help remove some barriers. So common barriers include stigma, the barrier of geographic distance, community opposition to physical supervised consumption services. Some sites have limited hours of supervised consumption. So we're hoping to deal with that. And then if a client is in extreme amounts of withdrawal, they often just use and don't make it to supervised consumption sites. So we're hoping to deal with that barrier as well by having the service. We're still in the process of figuring out how the service will look beyond our 15-person trial. But we have had permission now from AHS to expand province-wide during our COVID period. So hopefully that'll happen, but it might take a few weeks in the bare minimum to get this up and running. So some recovery-oriented resources that are available. So there's 12-step online meetings that are available. I usually just tell my clients to Google 12-step online, and there's numerous resources. We've been doing this for a while now, especially in my rural communities that I work with. And they've worked fairly effectively. A lot of my clients state that they do find benefit from this method, just because there's that extra added anonymity. They don't know people in their community this way. They feel like they don't have to share their face sometimes as well, which is a benefit. So again, a lot of positives from these 12-step online meetings. On the flip side of things, I do have some of my clients who also tell me that they do like that one-on-one, not the one-on-one, sorry, the in-person experience as well. And they feel that's better, and the relationships they develop with these individuals within their community is beneficial for their recovery. Other resources include AA Sober Living, Smart Recovery. So SMART is often a reasonable way of engaging with clients in group therapy as well, just because they don't have that spiritual aspect behind it that a lot of people dislike with the AA meetings. So definitely an option there with this. There's also In the Rooms, which offers support for families as well. They embrace multiple ways of recovery, including 12-step, non-12-step, wellness and mental health modalities, and then the Daily Pledge, which is through the Betty Ford Foundation, which is again more of a discussion forum, but also has some group sessions as well. A lot of fun things that happen there too, with fun and photo sessions. So you can check some of these resources out. And then managed substances during the COVID-19 pandemic. So a lot of you probably know of this as being safe supply, and in many respects it is. We've kind of pivoted the language on this a tiny bit. And I think needs to be a bit more definition around what safe supply actually is. And I think there's various aspects of safe supply that people are encouraging or like to use, are enthusiastic about, but others that are a bit more worrisome. And it's, really much, if you are going to practice this, it's very much based on your comfort level. And again, open to discussion afterwards. I know a lot of you guys are quite versed in this on the phone line. But we're calling it managed substances because there's still daily dosing, if not witnessed. And you're still managing the clients on a regular basis and making sure they're doing okay, as opposed to giving them a bunch of supply and letting them off on their own. And I think that's a distinction that I want to make with safe supply from what I've seen some people do versus what I tend to do. Again, I don't call it safe supply just because I'm still dealing with the client on a regular basis, or someone in the healthcare system is dealing with the client on a daily basis. So, so the whole concept of this is during the COVID period, we want to make sure that our clients who are isolated stay isolated and are supported with their substance use, and they're not going through withdrawal, and they're not feeling cravings if possible, which might be hard to do. So the key steps to this is, number one, you have to make sure that they're have COVID positivity or are suspected of having COVID, and be self-isolated. Number two, they have to have an active substance use disorder of some sort. And then number three, be deemed at high risk of withdrawal or overdose, not be able to achieve therapeutic dose with what's currently available with their OAT or what they're getting from the streets, and experience homelessness, shelter living, or being in supportive housing facility, and again, deemed unable to self-isolate at a high risk of flight. And so what we've been suggesting to do, again, it's all based off the BCCSU and Christy Sutherland, and she shared a bunch of her stuff with me a couple months ago, is providing oral hydromorphone or DILIs, 8 milligram tablets, 1 to 3 tabs, Q1H as needed. And of course, there's a maximum dose on this. And MS-Lon as well, if needed. And a lot of the times the clients decide themselves what they want. So Christy says that she's been doing this for a while now, and she's had no major complications. And in fact, when she does provide this to clients as a first line therapy, which is not what I do, I usually provide as a last line therapy, she finds that there's reasonable uptake to treatment as well. So they often will transition over to OAT, whether that's methadone or Suboxone. This in particular is not a form of OAT though, and there's a clear distinction here. This is providing clients with doses so they can manage their own substance use, but it's not OAT, but it does lead to some of the things that we want to achieve with OAT. So she reports that they've achieved a lot of social stability, a lot of them engaged with their family, have had improvements in their quality of life. So again, important distinction, but it does carry a lot of the same benefits. The thing with oral hydromorphone though is that what she does is that she allows clients to come and get the dosing from OPSs or supervised consumption services. They come in, they get their dosing, and then they leave, and they come in and out as they want, again, up to 14 tablets a day. Stimulants, so for this, again, it's not a replacement of the stimulant use, and it's not used to treat their stimulant use. It's there just to quell some of the cravings potentially, as well as quell some of the withdrawal symptoms that they might experience. And that's how, especially people at the BCCS who have been using this. So they use dextroamphetamines and then methylphenidate as well, which is basically Ritalin. And they use the doses that are usually used for ADHD. Ideally, you use higher doses than this. That would be more impactful, I should say, for stimulant use disorder. So that's just the one thing to be aware of. And so what I've done with my clients at IOT, for example, is that I've started them with dextroamphetamine, and I've increased their doses and titrated to a certain amount, just to help them decrease their overall usage of amphetamines. For benzos, basically what I do for them is that I dose convert them to clonazepam or diazepam, and then basically half the dose if necessary, and then titrate up or down as needed as well. And then I titrate them down slowly over a period of months to even a year. So it does take some time to do. But the usual way of doing this is clonazepam. That's the easiest way to do it. Give them a daily dose of clonazepam, use a long-acting form.